recording
Yeah.
to the cloud. I'm pretty sure.
Right, we're recording.
We are, and we're 5 minutes in, so we're probably going to start. All you lucky people. I
Yeah.
really appreciate all of your coming. Tracy, you were going to start us off. You want to do that?
I can, sure. Thanks so much for being here today, everybody. And this also is part of our Get Ready curriculum that is just preparing us for the challenges and opportunities and growing older in a changing world. And we're so blessed to have Betsy Weiss as one of the leaders in helping to craft this ongoing curriculum that will be
How my numbers go?
changing.
Where did my?
You want? I have.
You might have to do some
I was just
muting,
gonna start.
Betsy.
I'm going to mute you all, and well, I'll unmute you a little later, just for the moment. Okay. Actually, I'm going to unmute Tracy. Tracy, you better unmute you, huh?
Here, I'll unmute me. Okay. I know the joys of, our informal Zooms, but it's great to have these recordings on the YouTube channel. And if any of you haven't been onto our YouTube channel, there's a lot of great programs on there. And so, as I was saying, we're really fortunate to have Betsy on the team in so many different capacities as one of the main founders of Met How at Home, and also staying on to help us develop this preparedness curriculum. And part of that is to just have these conversations around, what are things to think about in terms of dementia? What are some ways that we could be more prepared, have difficult conversations so that we have things in place just in case we do go into cognitive decline. A lot of times we won't necessarily realize that that is what is happening. And so thanks so much for joining today. And I'll hand it back to you, Betsy.
Well, thank you all for being here. I appreciate it, and appreciate the opportunity. This is actually a subject that I think about a lot, having had dementia in my family, and having a mother who was incredibly comfortable talking about all kinds of really uncomfortable stuff, like what do you want to wear to the crematorium and things like that. But a lot of the questions that come up around developing dementia are not things that we talk about very easily. And I think one of the things that in the Get Ready curriculum, we have a sort of a core belief that is that if we don't talk about it and don't consider it, we lose choice, and we lose the ability to have some control over our own destinies as we face these challenges. I mean, I have seen this over and over again, and I've also seen how not having conversations about the choices can end up really hurting the people who are caring for us, because we create expectations or imply things get left unsaid, so that assumptions are made when they're not necessarily the true assumptions, because you haven't had the opportunity to talk about it. I am gonna cheat and go to a slideshow because it was my memory is too short to try to hold all these things in my brain. I would love to have any of you who want to enter in the chat specific questions you hope to have answered during this time. And also, you should feel free to unmute yourself and interrupt me if you've got a question or something that you want to bring up. Your voices and experience are super important and will enrich this conversation a lot. So please don't be shy about speaking up. I very much appreciate hearing from you. So I'm going to share my screen. And then I'm going to go back to the top of the slide. This slide has very little to do with dementia. It's me on a Hawkwatch event soon after we got here. And it's a reminder in my mind of staying in touch with the things that bring you joy and bring you meaning in your life. And that framework is essential in how you make decisions and how you make choices. It may be that the most important thing is to be able to look out the window and see the birds and drink your cup of whatever. Even if you're not recognizing people in your life, it may be that the thing that's most important is to be able to get out into the world and know that you have a sharp-shinned hawk on your fingertip. So, and everyone, it is astounding to me how different people are in how they frame joy. Or what is most important to bring them joy in their life. So unless you communicate that, your people who are going to be making decisions for you aren't going to know what matters. This is a brief outline of what we're going to cover, a little bit about what our world is facing in terms of the rise of dementia and are having to deal with it as an issue. Why we say hope for the best and prepare for the worst. What is the legal status of a dementia directive? I don't have to read all this. But a dementia directive is different from a regular healthcare directive. A regular healthcare directive applies to those times when you are critically ill, possibly terminally ill, and can't speak for yourself. A dementia directive addresses decision-making when you have lost capacity to make in the area of executive functioning and decision-making. We'll talk a little bit about what other kinds of documents you might want to consider. I'm not going to address all of those, but I'm going to give you some resources about where to find them. And we will always have more discussion about the things that are left out today. We plan, Tracy and I plan to send you all links to anything that is raised here. So don't feel like you have to try to scratch them all down on a note card, because my experience with doing that is very frustrating and not very effective. Dementia is an epidemic in this country. And as we age, it is something that we see in the people we love and in the people we live next to, and it is becoming an increasing problem, partly because of all the problems with trying to find caregivers for people as they lose capacity. For people over age 85, about a third of the population will have dementia. Most people now speak of dementia as Alzheimer's is considered the most common. It's about 85% of dementias, but in fact, most Alzheimer's is not just Alzheimer's. It's probably more complicated than that. It's probably a mixed process. People with vascular dementia probably have a little bit of Alzheimer's. People with alcoholic dementia probably have a little bit of Alzheimer's. People with Lewy bodies dementia probably have some component of neurotangle. So it's interesting that making the distinctions between the types of dementia can be helpful in a given case, but the big picture is that over 85, about a third of us will have some form of dementia. In the state of, I have to reduce my side view because I can't see what I'm saying here. This is a projection of numbers in the state of Washington that from 2020 to 2025, there's going to be an increase of about a sixth. We're going to go from 120 to 140 people who are suffering from dementia. What is a dementia directive? So again, the distinction between a healthcare directive and a dementia directive is that a dementia directive comes into play when someone begins to lose cognitive functioning and capacity to make decision-making, to make decisions for themselves. In a standard healthcare directive, the situation that comes into play is usually with a severe illness or terminal illness, when the person is so sick that they are not able to make decisions for themselves, and usually it's and addresses more end of life kinds of choices. Mental health directives came into existence in the state of Washington in 2002, and they are legal documents in the state of Washington. If you have one, the person who you designate as your decision maker is not obligated to follow your wishes, but they're obligated to honor your wishes to the fullest extent possible. And the fullest extent possible can be limited by finance, by the fact that they work full time and they can't be there to care for you, and that's what you asked for. They can, any number of things can be a barrier to actually honoring the requests laid out in a dementia directive. And it is super important, just like with a regular healthcare directive, to discuss your wishes, if that's possible, with the person you designate as your decision maker, because they may know right off the bat that they're not able to do what you're asking them to do, or that there are challenges for them to try to meet your needs in the way that you hope to have them met. So that those discussions remain as important with this document as with any other. You have to be competent to create a directive. That doesn't mean you have to know exactly what day it is and what the hour is, and to be able to draw the face of a clock, which is what we do when we're testing somebody's cognitive function sometimes. But it does mean that you have to be grounded in the real world. You can't be so impaired as to not have reasonable cognitive function. Right now, there are two main tools that are out there for people to use to guide people through this process. One is one that was developed by a University of Washington professor, geriatrics professor. His is super simple, and I'll start with that one. The other one is one that was developed by End of Life Washington, and it was developed by a guy who was really active in the AIDS community and saw people develop loss of cognitive capacity from a variety of situations. And it's much more detailed, much more specific, and each one has a place. and we'll go over a little bit about the difference. Each one is a legal document in the state of Washington. Not all states honor a mental health directive. So if you take it, you have to check with where you are to decide if to know if you move to Tucson, whether it's going to be legitimate or not. I'm going to go back to this. Having your people get a sense of what matters most to you is extremely important. If you get enormous pleasure out of looking out the window and don't mind having people care for you in intimate ways and change your clothes and those kinds of things, and don't really have a need to relate to the people that are important to you in your life, that's really important to share with the people who are your decision makers. If what's most important to you is your relational being and language and being able to engage around ideas, that's also important to share because it shapes decision making. I mentioned lifestyle elements because Sheila Brandenburg always mentions is that what's important to her is that she have her cup of coffee in the morning. And I have to admit, that's pretty important to me too. One piece that gets left out a lot, and people in the US often have this sense that choices should be unlimited. But the fact is, this care of older people is very expensive once you start moving outside of the home, and that making plans for that and making it clear what matters to you about that is a really important piece that will assist your decision makers as they work through these issues with you. I'm gonna think I'll stop for a second and see if there are any particular questions from anybody right now. If not, I'm just gonna go back to my slides.
What if
Go ahead.
Yeah, well, what if like my grandmother, she really, she had dementia and she really didn't want to go to the end stage of that disease. But, her doctor said that there was no death with dignity law that could apply to her because her health was too good. And so it was just really tough. She wasn't really having her wishes met. And
we'll talk about that a little bit more down the road.
Okay.
There are a couple of things you can decide with mild dementia, in the first advanced directive. You can decide with mild dementia, moderate dementia, severe dementia, the extent of care that you want, the extent of interventions that you want. But the big thing that has become a topic of discussion in the state of Washington and really across the nation is the concept of using voluntarily stopping eating and drinking at a point when you have enough awareness about what's happening to you that you can, usually this would be in mild dementia, close to moderate dementia. You have to have enough awareness about what's happening that you can make the decision that you're going to stop eating and drinking. And we are going to have a full discussion about this at a later session with a woman who's had a lot of experience with it and a lot of experience supporting through people as they die with that choice. Usually it involves some sedation, and usually will take between 7 and 10 days. But we'll come back to that, because that's an important topic for further discussion. Okay, anything else that anybody wants to bring up now, or I'll go back to the slides. So the first directive, the one that was designed by the guy from the University of Washington, divides dementia is categorized into stages: first, second, and third, mild, moderate, severe. And what I want you to do as you look at these stages is to sort of put yourself there, to imagine being at a place where you were beginning to lose your recent memory. You're not forming new memories. So you're the person who repeats themselves with the same story over and over again. You are having difficulty remembering the steps of making beans and rice. You don't have the reflexes and processing ability to be able to deal with an emergency on the road particularly easily. So maybe you shouldn't be driving. So I want you to just put yourself in that state and see what it feels like to you. You may have people in your life who love you and are caring for you. You may be in a living situation where you're well cared for. You may be living alone and not have any of that stuff. But just feel what it might feel like. And then we're going to go on to moderate dementia. And in moderate dementia, it's you might be having more trouble with language. Not everyone does, but language, you might be having more trouble holding on to a thought, complete a thought. You might be more tuned into feelings than to actual flow of what's going on around you. So you may be at your family setting up a family dinner, and there's a certain amount of chaos, and you're feeling the chaos, but you don't really have a good sense of what it's for. Or, if you might have a sense whether it's good chaos or bad chaos, but you don't really understand what's going on. And you need a lot of cueing around that kind of stuff. You probably require help picking out your appropriate clothing, and may have some issues around continence and toileting. And so you're cared for in those ways. And so maybe you're in a place where somebody puts cream on your feet and massages your feet and hands, washes your hair. How does that feel to you? Does that feel good? Does that feel like a loss of autonomy? Does it feel like you're loved and cared for? Is losing communication? Where does that fit into your hierarchy of values? And the third stage is really when you stop recognizing the people who you love and who love you. You may be disruptive, you may be serene. I remember a woman who used to pace the halls of the nursing home where I would care for some people, and just had this look of such discomfort on her face. She didn't have outbursts, but she just, she had this tension in her whole being. I can think of another person who, again, could sit by the window and you'd hold her hand and she would just seem to be, you would become peaceful sitting with her, because what she projected was this calm and gentleness. Usually at this stage, you need full body support and care. So what this advanced directive asks for is simply to establish health care goals. And it's like your more traditional advanced care plan. At your given stage of dementia, where do you put your priorities? I want to live as long as I can with full support. If my heart stops beating, I've got mild dementia. Why don't I just, if my heart stops, I'm pretty happy. Why don't I just have it restarted? The second option would be to receive treatments that would prolong your life, which might include some blood pressure support, or we're talking about pretty big events here. And you can read through the other options. I think the point that I would make about any of these choices for somebody with dementia is that if something dramatic and big happens that requires a hospitalization or a major medical intervention, say you had a bowel obstruction and we're going to have surgery on your bowel for that. You don't usually come back to where you were. If you start off with mild dementia going into that event, those things have a big effect on you. And even something like breaking a hip, you have to be able to cooperate with physical therapy when you get out in order to recover from a fractured hip or a fractured leg. And all those things are hard, and they're harder with dementia. And so as you make these decisions, you have to consider that and consider not just treatment for the acute event and the likelihood of recovering from it, but what will that recovery look like? And I would say that as you think about this, the important thing is that you think about what matters to you and what your situation is and what the consequences of a change in your status are going to be for you. So that's the first advanced directive. That's all it includes: the 3 stages of dementia and establishing a limit of care at each level of dementia. The second advanced our dementia directive is this mental health directive that was developed by End of Life Washington, and it has a lot more detail in it, and nobody's obligated to fill out every part of that, but I think the reason it's most helpful is because it sort of forces you to think about stuff that you wouldn't think about otherwise. It starts off with these questions. Do I want this to become effective right away? When can I revoke it? One of the things that can happen is as you lose mental capacity and executive functioning, you might say something different down the road than you said when you went into this. If you have, you're not demented at all, and I say, I'm pretty clear I wouldn't want to be resuscitated if I were demented and I had if I had a diagnosis of dementia and I had a catastrophic event. I would not want to be resuscitated. Well, down the road, I would not want to have major surgery that was 50%, gave me a 50% chance of survival. Down the road, I'm in that situation and I've got moderate dementia. I don't have the same level of executive functioning that I had when I wrote my advanced directive. And I'm saying, I want you to take care of me. And the doctor says, do you want me to operate on you? Of course I want you to operate on me. But so you're deciding here whether you can revoke your directive or not. And if I said I don't want to be able to revoke my directive, then what I am asking my decision maker to do is to say they were very clear that they didn't want this kind of care in this situation when they designed this, and that they did not want to revoke their directive under these circumstances. So we want you to treat Betsy for comfort and not do this major surgical procedure. So, or I might say, I want to be able to revoke this directive whenever I want. And I don't care if I'm not thinking the way I used to think. I don't care if I'm moderately demented. I want to be in charge. And if I want to revoke it, I want to revoke it. And then your decision maker has to honor that. You have to decide, like a medical power of attorney, you have to decide who is your medical healthcare agent. That's the term for this particular form. And and then you spell out what you want them to do, that they're going to decide what kind of care you're going to receive, that they're going to decide where your care is going to be given, how your assets are going to be spent to support your care, and all of those things. I mean, you can lay it out here. And so what are the kinds of things that you want to include in this? And it's all laid out for you. You're cued about all of this. Almost everybody seems to like the idea of being taken care of in their home. Not everybody. You like the idea of being taken care of in your home, but maybe you don't like the idea of being taken care of by your family. Maybe you want to be taken care of by a caregiver, or maybe you only want to be taken care of by your family. Now this is where I think it's super important to discuss this with your healthcare your agent, and also with the people who you have expectations of, because it may be super hard for somebody to do this. They're for all kinds of reasons, because they're working full-time, because they have other responsibilities, because they're whatever. You can say, my first choice would be to be cared for in my home, but I recognize that may not be possible, and I would be willing to accept out-of-home placement. My first choice it is, again, really nice if you can, if you know a little bit about what's out there for options. So you can say, I love the idea of an adult family home, or I really like being near more of my children, or whatever. I mean, you think about those things, about what does out-of-home placement mean for options, and do you have strong feelings about where you'd want to be placed? The management of disruptive behavior. Most of the time, this comes really in moderate to severe dementia. It can be wandering. It can be being up all night. It can be making singing in the middle of the night, or any number of things. It can be hitting, it can be walking into other people's rooms and being sexually aggressive. So how do you, giving permission to manage those things with usually it's with medication, can really be a relief for your decision makers, because these are hard, these are difficult. It's hard to find perfect solutions. Oftentimes the medication can do something more than what you hope it will. So giving people permission to manage disruptive behavior is helpful. Almost everyone these days tries very hard to deal with disruptive behavior behaviorally. And by that I mean, if you're in a facility which deals with people with dementia, and you're one of those people who tends to be up all night, staffing might be such that you're allowed to be up in the night and then sleep during the day. And there can be an effort to try to regulate your patterns of sleep. So most dementia facilities really try to manage these things, these difficult behaviors, not through simply sedating people into compliance, which used to be the way things would happen, but that's not so much the way things happen now. If somebody's yeah, and it depends on the behavior and it depends on where they are. Preferences about financing care is huge. This is a huge topic and one that deserves its own hour-long talk at the least. If you have unlimited resources, it's really not a big issue, but I would say that doesn't apply to very many people. Almost everybody has limited resources in some way. As most of you are aware, the cost of care at home now here for a caregiver is about between, I mean, you can maybe find somebody for $25 an hour, but really $35 an hour is probably more consistent with the going rate. And you multiply that out, if you need 24-hour care, it's a lot of money. And the average cost of care in a nursing home in Washington State, I believe, is like $9,600 a month. That's average. And these numbers are only going up. And the cost is dependent on how much care someone needs. Obviously, if someone with dementia needs significant supervision, you're not going to be leaving them home alone at night, because they won't know what to do if there's a fire, even if they're good sleepers. You know, you're not gonna leave them to be a problem solver alone in their own home. So that means providing supervised care, and the cost of that is a lot. The options for financing care and sheltering some assets are many. There are options like reverse mortgages. There is now, there are new rules about how much money can be sheltered. A spouse can stay in the home after a person, even if a person requires care in a facility. Anyway, there are a lot of nuances to financing care and estate planning. And if you have any kind of an estate and savings, it is well worth meeting with somebody who's an expert in estate planning around this issue and discussing the issue of long-term care. Almost any long-term care policy has limits, and 1 to 2 years of care can provide significant support and relief. But for most people with a dementia, don't cover the duration of time that they need as support and assistance. And I would say with moderate or severe dementia, it is incredibly hard to provide that at home with a single primary caregiver. It just is incredibly wearing. I'm not an expert on the intimate relations discussion, but one of the things that comes up and is I think is helpful to talk about before you get there is how you would feel if your partner, say I'm the demented one, if my partner, I'm in a facility, or I'm in a facility, how would I feel about them developing a relationship outside of our marriage? And having that discussion ahead of time relieves just a huge amount of trauma and guilt. The other side of that is that there are people who develop intimate relationships in a facility, and having some discussion about that is also helpful, just to ease people's pain and sense of rejection. The consent around suspension of driving privileges, that has to be discussed really early, preferably before you have dementia. And the idea is that you give consent to giving up driving when someone in your world says it's time. And that is, again, you may get to that point where you say, okay, you've got late mild dementia, but you've had an accident in the parking lot at Hank's, and you're driving way too far to the side of the road when you're out on the road, and you've given your agent the authority to tell you when it's time to stop. Being able to remind me that I gave my agent this task to tell me when I can't drive safely anymore is very helpful. And I'm more likely to consent to that decision if I considered it and gave it in advance. Now, I might not choose my agent to be the one to tell me. I might choose my healthcare provider to be the one to tell me. And then another thing in this directive includes, do you want to be your guardian if you need a guardian? And most people designate their mental health agent as the person they would want the court to appoint as a guardian. Any questions in any of that? Not, I'm going to keep going. Is it? Other things to consider are a regular power of attorney for finance and for medical issues. And A regular power of attorney for medical issues is different from this mental health directive. And we've had a lot of discussion about those. Doing the work of becoming a financial and legal power of attorney is well worth it. And I would say most of you have probably already done that. A pulsed form is something that I think many of you are aware of. It's been brought up in the discussions around medical advanced directives. A physician's order for life-sustaining treatment is the order that you have in your home. It's on a bright green sheet, and it is a doctor's order that gives guidance to emergency medical people if they come to your home and care is to be given. So it can say that you do not want to be resuscitated. It can say you do want to be resuscitated. It says you want comfort treatment. It can say you want everything short of intubation and your heart shocked. It can say you can have specific guidance. These pulse forms are good for a year and need to be, and as I say, they need to be signed both by you and by your physician or your healthcare provider. Estate planning, I strongly recommend this. We're going to have a discussion, I hope, later in the year with aging and adult care around the Medicaid rules. And Medicaid is, I think most of you know, is the insurance that pays for nursing home care and adult family homes. And it's a income-based program. Oh, good. Marcia's raised her hand. Can you speak, Marcia, or?
I can speak. Can you hear me?
Yeah, I can.
Okay, so I'm just going back to the pulse form only being good for a year. What do you mean? You have to redo your pulse form every year?
It's supposed to be renewed, yeah.
So you redo a form and with a new date on it every year. I've never heard that before. So that's a total new information to me. Okay. Huh. Huh.
I would say that happens very rarely.
But
theoretically, they're supposed to be renewed every year.
I'm lowering my hand.
Okay. Do you have anything to say about Medicaid? You want to add any? No. I'm not sure I'm the best person to discuss Medicaid eligibility, but basically the way most people pay for long-term care is by spending down their estate, and so they pay privately for the first few years. But say you've got, well, now since all our houses are worth $5 billion in the Valley, maybe we have enough to we had a reverse mortgage on our homes to pay for several years of long-term care. But most of the time, you know, if a year of nursing home care costs $120,000 or more, then you can see how an estate would dwindle quickly. And, you know, I think where people get stuck is where their goal is to leave money to their family. And rather than use their estate to care for themselves. And there are ways to shelter some money, but really your money will almost certainly be used to care for you. Wills are really helpful too, and naming a personal representative to be your estate, your executor, is very helpful. Sharing what's in your will with your family is very helpful, because to reduce conflict after you die. And lastly, learning about voluntarily stopping eating and drinking. For the thing that many people think of death with dignity as a potential tool if they have dementia. But in fact, dementia is not considered a terminal illness. And people can live many, many years with dementia. And I mean, certainly people die of dementia, but one of the criteria for being able to use death with dignity is that you're competent and you're able to take the meds. And the way people die from dementia is they're basically our bodies involute, and we lose the ability to eat, and we lose the ability to use our muscles, and we lose the ability to control our bladder and bowel. And when you die strictly of dementia, mostly it's a wasting kind of disease, and you're not in any position to make a decision about taking death with dignity meds or even take the meds. But if you know that you don't want to progress in a dementia, voluntarily stopping eating and drinking has been something that's been used successfully and gracefully by many people in this state at this point, and really across the country. But it takes planning, it takes discussion, and it takes support. It's not something that it's possible to do without a lot of conversation and support. And again, we'll have another program on that I think will be really great, because the person who's giving it has had a lot of experience. So there are also a couple of programs that I think are well worth learning about, and we'll send you all these links. There's a legal planning toolkit through Northwest Justice Project, and the Pro Bono Council of Washington has started a program. There's a lot of concern about the fact that we're going to have 140,000 people with dementia by 2025. And more people in our world are going to be dealing with all these problems. So the state has really worked hard to develop tools for educating people and preparing people for this possibility. And the Pro Bono Council is a legal group that will, that anyone who's over 60 can access to help you work through the steps of developing an advanced directive, a financial power of attorney, a medical power of attorney, and a few other, and a dementia directive. So if anybody's interested in that, we'll send out that information as well. And theoretically, all you have to do is be over 60, and you can call them and they will help you and consult with you on all these issues. So that's pretty cool, I think. The advanced care planning tools. And lastly, I think one of the areas that we often forget is what happens after we die. And this is a list from End of Life Washington, but really it's bigger than this. This is a lot of the legal stuff, like notifying Social Security and how many death certificates to get, and getting off the internet and all that kind of thing. But the other part is that aspect of ceremony and easing grief that I think really can, having some discussion around this with the people in your life who matter to you, allows you to shape an event, a moment of coming together that will have meaning for you and those people. And I encourage you, we're going to also have more discussions around this kind of issue as time passes. And I think it's a rich one. You know, when we first started Meadow at Home, I remember we were talking about advanced care planning, and somebody said, geez, why do you want to talk about all this dark, sad stuff? And I just, you know, I think this is something that all of us face and have to deal with. And I think it allows, the conversations are an act of love, and they really do give us the opportunity to come together and share what's most important to us. So that's the end.
I have a question, Betsy.
Thank you all. Yes.
Well, first, thank you. What a wonderful presentation. I'm curious, as you know, how one gets a, can you go in the other room? Gets a diagnosis. And are there more, do you think that in the future, you know, that in time people can get diagnosis with, you know, whether or not one has mild, moderate, or severe? I imagine if you have severe, you are already there, but for people who would want to know, you know, so they could make plans. And I know there's advances going on all the time with theoretically, you know, with medications, but it seems like if one, I can just speak for myself, and I have talked to my family about this, but in fact, my son, and we had a little family gathering because my son was in town, and I spoke to several people about my desire to not want to live with severe dementia. And I know when one is in a state of severe dementia, we can't make that decision for ourselves. And even with these, you know, even with a directive, it seems to me that we can't direct our family members or our healthcare provider to put us on a stop eating and drinking program. I don't know, I might be wrong about that, but I'm hoping that down the line there'll be some ways of, you know, getting a firm diagnosis and being able to plan for that with your family and your loved ones and friends, and what one's wishes might be.
So I think you raised lots of really excellent questions, and you are so let me break it apart a little bit. There are tools to assess memory that are standardized, and there are two primary ones. One's considered a little bit better than the other for office tools. And usually what you're looking for with a dementia is progression over time. So a single measure of your memory is not particularly helpful, but doing it once and then doing it again 6 months later gives you some idea over time if there's been change. So that is the sort of the initial clinical screen that is generally used. There's fancier tools. People who are super well educated tend to do better on these kinds of things. It often can be harder to make an early diagnosis. They're looking for other things that might be, which is the question that Carlin raised earlier, looking for other things that might be affecting one's cognitive functioning is also something that's important. So bringing this question to your healthcare provider, I think, is really important. And whether or not you get an MRI or PET scans are supposed to be more sensitive than MRIs. It's not just how much brain is there. It's and what you see on those things. But most people don't feel you have to have a visit with a neurologist. But again, this is a big diagnosis, and if you're thinking about doing something like making a serious decision, a serious plan that might shorten your life, you want to be pretty sure you know what you're dealing with. So you might decide you want to see a neurologist as well, even if your primary care provider says, I see no complicating factors. I'm measuring cognitive loss that's progressive. This seems like it walks like a duck. You know what I mean? This is dementia. And they're, getting a second opinion. I'm a big believer in second opinions. So if you're not sure, get it. And if it doesn't feel right to you, get it. So say you've got a diagnosis and it's not just mild cognitive impairment. Much of the information we're seeing these days suggests that a significant portion of people who are diagnosed with mild cognitive impairment actually have a progressive memory loss. Now, again, all of us have most of us in this room are old. I'm not sure all of us are old. Tracy, you don't count. Carlin, I'm not sure you count either. You may not be old enough. And who's Jamie? You're a spring chicken. So, what was I going to say? Most of us have more trouble learning new things than we used to. That's just a fact. It's harder for me to learn my Spanish now than new Spanish now than it used to be. And that's not dementia. That's full brains or whatever. That's something else. But if I were tested in the ways that these standardized tools, and I have a score that's impaired, and then in 6 months I get tested again and I'm more impaired, and there are no complicating factors, and there are no I'm not depressed, I'm not stressed, my B12 is fine, my electrolytes are, the whole list, it's all okay, I don't have a brain tumor, then looks like it's probably dementia. And I might choose, since I have pretty serious consequences, I think for myself, if I have that diagnosis, I might want to get a second opinion. But the drugs, you are absolutely right. There's a tremendous, people are very aware of this problem, and it is getting there. There are more and more people who are going to be suffering from this condition. And whether it's monoclonal antibodies to amyloid or whether it's something else, it's quite likely that there will be some advance that might alter the course of this illness. But I really don't believe we have that yet. Even with the new drug that was developed by the new monoclonal drug that's been developed and under a lot of duress approved by the FDA. So then your next question is how do you plan? And you have to plan before you have moderate dementia. You have to make your plans before you get there. If once you get there, it's just too late. And that means having discussions. And I have had people in my life who have told their families that they want to be taken out on the ice floe, you know, literally taken it on up a mountain and left. That is not a kind thing to do, to give your family that that kind of charge. First of all, it's against the law. And second of all, it is incredibly painful to ask people who love you to do that. Asking them to support you and to be comfortable in your home, stopping eating and drinking where you're making a conscious choice, I think can be something that families can feel really good about. But when people are severely demented, they will stop eating and drinking. And one of the things that happens in a facility often is that since care can be equated with feeding people, it's hard for the caregivers to let go of it. It's a way of nurturing that feels important and caring, and to let somebody stop eating when they're not interested in eating can be very hard for caregivers. So it takes a lot of deliberateness if that's the choice that you make in a facility. In a home, it's easier to do that, to let the person be in charge of that, for it to feel like it's their choice. Other comments? Or we've got a lot of experience in this room.
I just want to say that.
What did I leave out? I'm sorry.
Oh no, my connection has been a little bit spotty. I just wanted to say that on the VSED website, voluntary stopping eating and drinking, I don't know if it's Washington or just the VSED website, there are some very beautiful stories and full videos of the process that made me like, oh, understand it and a lot more. So, and I'm sure, as Betsy says, we'll learn more from Nancy. That's going to be on April 19th. So. Yeah, thanks so much, Betsy, for compiling.
What's late? Yeah, you've been really patient with me. Okay, thank you all for coming.
Thank you. This was a wonderful presentation. Thank you.
Thanks,
Thank you,
Betsy,
Carlin.
Tracy, and all the other participants.
Thank you. I have another quick question, maybe.
Yeah.
Or anybody who wants to leave should feel free.
So I'm curious, you know.
Feel free to leave if you want.
Yeah. First of all,
Go ahead.
I don't have this diagnosis and I don't feel like I have it now, but I'm thinking about the future. But, and in thinking about the future, I also think about getting a good personal health care, agent or personal agent. And, you know, if as we age, as I get older, and I don't want a family member to have to make those difficult decisions, and I want to find another personal agent or a healthcare agent. And I think of many or several in the Valley, but as those people get older, who am I going to find? And the question is, you know, are people being, is there a field in the healthcare and the medical care for people to be trained in this and to be paid for it if that needs to be done?
That's a very interesting question. You know, there are people who don't have family, who don't have somebody who is an obvious choice of being to designate as their decision maker. And it's hard. And it may well be an area that becomes more identified as, I mean, we have death doulas, we have birth doulas, maybe there is a place that I think lawyers have been financial and legal agents plenty, and some of them have taken on the role of healthcare agent, but I don't think in general they like to do it. And I mean, it's a really, really important question, and I don't think I have an answer. Does somebody else that want to speak to it a little bit? Mel, do you have a comment? Oh, Lucinda.
I don't really have an answer, but one of the things I am considering is basically cultivating a relationship with somebody who's kind of family, or someone who's not my direct family, like a second cousin's child, you know, so someone we sort of know who isn't my generation. So they'll be alive, you know, they'll be able to think, and to actually make it, you know, to cultivate the relationship as a way of developing a relationship with them, but also to pay them for it, so that you pay them an annual stipend for tracking you through time and taking you to the point that, you know, you have these decisions to make. And it's kind of also a way of not requiring them to wait until you die to receive some kind of financial benefit for things. Anyway, just a thought, not like it's the answer for everybody, but.
I think it is true that not everybody who is the obvious choice is the right choice too. And that your partner may have a lot of trouble making decisions that you think are right for you, and that you've laid out, and may have a lot of difficulty with the choices that you make. And that's part of why it's so important to talk about it ahead of time. But the concept of kind of deliberately cultivating a relationship is an interesting one. I like that idea.
Mm-hmm.
I also think that most people, when asked, feel like this is an honor, not a burden. It is big. And with dementia particularly, the consequences are bigger as the disease progresses. Lucinda?
I wanted to jump back in for a second because I think using the word cultivate might have sounded kind of usury almost. I mean, I don't mean it that way. It felt what I mean it more as, you know, somebody that you already have a relationship with, and you basically ask them if they're willing to deepen their relationship with you in this way. So I think I might have sounded kind of, I don't know what,
No,
but
don't worry. We know what you meant.
I thought it's a beautiful idea. Yeah.
Okay, you've been very patient. We really appreciate the discussion.
Yeah.
Any last words of wisdom? Again, thank you so much for being here.
Thank you.
Yeah. Thank you so much, Betsy, for just putting this together. And now we'll have this recording. And there's a lot of state entities that are working on this. And I think there's a lot of work that's happening that doesn't get communicated. So thanks so much, everyone, for being here, and spread the word and share.
And we'll send you all the links.
Yeah,
Thank you.
we'll send you the links.
Oh, Lucinda.
I'm going to just ask a question. I follow on with all this stuff that may not be going on, or is there a way that, or we may not know about, is there a way that Meto at Home could, I don't know, advocate with some state organizations or even Room One, or to come up with a program to have people who can be mental health care agents, so that that you could interview, not interview them, but that anyway, that basically we could become part of creating a pool of people for those of us who don't have someone.
That's an out of the box idea. Yeah, we'll put it in the hopper with with our other ideas. But I think that that's one of the beauty of having conversations like this. So, all right. Yeah, thanks, Kathy. Oh, I'll have to meet you sometime in person. Thank you for all your help lately, Kathy. All right. So good to see you all. Good to see you, Carlin, and blessings.
Leah, thank you for being here.
Thanks to all of
Okay.
you.
Thanks for